Good morning, everybody. My name is Ann Kempski, and I'm an independent health policy consultant that has the great good fortune of collaborating with many of the researchers whose names you've seen on these studies that Jerry has talked about this morning. And part of my role is to disseminate the results. So that's why I'm here this morning, and I'm very excited to be surrounded by so many experts in different disciplines coming together. There's a lot of research here to digest, I think. When I step back and think about community benefit and this evolution, this incredible evolution we've seen in hospitals over 100 years, I'm glad that Jerry started with this evolution from simply being a place to perhaps just go and convalesce, to getting well, to getting cured, to getting compassionate care, to getting incredibly high-tech care that restores people's health. And we never want to lose sight of that, right? When we look at these sort of abstract data points, and that inside these hospitals there are very top quality, top-notch people every day working 3 shifts and taking care of us. And when I think about all of this research that Jerry just went through, I sort of think of it as in these 4 themes that tee up our session very nicely. And the title of our session is The Hospital Industry: Policy, Mission, and Accountability. And I think of the first theme that Jerry touched on, which is really we're spending a lot of money, hospitals are spending a lot of money on community benefit, and the dollar figures over 100 billion, almost 150 billion. Is it improving community outcomes? Can we see that in the data? And then secondly, when I think about the charity care question and should it be a community benefit, I think of the real question for me is, are we reaching with community benefits those most in need in our communities, those most at risk? And then I think the third thing that Jerry has really teed up for our panel is this question of across hospitals, how is this community benefit, call it a burden, call it a responsibility, being shared? And ultimately, if what we see is that a growing portion of community benefit is coming in this category of underpayments from government programs, is that really a differentiator, number one, for nonprofit hospitals? For-profit hospitals, experience that same underpayment. I'm sure they can show that on their income statements. And then secondly, who is ultimately actually shouldering this burden? I think that's the most provocative question that Jerry put on the table. And so I'm excited to introduce the panelists on session 1 who are going to tackle this from all of those angles, from the public health angle, from a legal angle, from the question of government oversight of this spending, and also from the question of who ultimately pays. And we have a speaker who really speaks for a labor management trust fund. It's called Health and Welfare Trust Fund that buys health coverage for rather modestly paid workers. And she will share sort of how they're approaching this issue. So with that, I'm going to go through who's going to speak in the order they're going to speak, and then our first speaker is going to be beamed in digitally, and if we can make that happen technically, we're doing great. So first, we're going to hear from Dr. Georges Benjamin. He is the CEO of the American Public Health Association, and then we're going to hear from Jill Manny, who is the executive director of the National Center on Philanthropy and the Law at NYU School of Law. Then we're going to hear from Sonya Phillips, who's an assistant director on strategic issues for the U.S. Government Accountability Office, better known in D.C. as the GAO. And then we're going to hear from Misha Sharp, who's the assistant director for policy for the 32BJ Benefit Fund. And with that, we'll start with Dr. Benjamin.
Hi, good morning, everyone. Hopefully you can hear me. We can bring my slides up. And I know that someone's going to move them for me. Thank you. So we can go to the next slide. And the next one, which is my obligatory outreach. That I don't have any financial disclosure issues or conflicts of interest. And then you go to the next slide. So I just want to remind people that public health is the one entity that has actually the core responsibility for public health. To improve the well-being of the population. This is derivative from the 10th Amendment of the Constitution, which gives us the authority and the police powers that public health has. But at the end of the day, your health department is fundamentally the chief health strategist of the community. Next slide. And this is an old responsibility. And public health has been doing community health assessments for many, many years, since 1799, when a well-known young man by the name of Paul Revere became the nation's first public health officer. And John Shattuck proposed these regulations at a time when they were concerned about cholera in Massachusetts. Next slide. Public health views the community health needs assessment from a public health perspective and a broad community perspective. Not only what it does in terms of being able to improve the health and well-being of the community, but also the benefit that it does for improving the accountability and the capacity of the health agencies to do their work. In many ways, this is our report card on whether or not we're successful in the work that we do. And so CHINA, in many ways, over the years, has been used by the health departments to, in a more holistic way, look at the health and well-being of the communities. Now, if you go to the next slide, again, we already know this. This is what Gerald, of course, just reminded us of. And of course, all of you in the audience pretty much know this. But nonprofit hospitals, that status is a tax status. It's run by an agency that is focused on money and the people that, not to demean our good friends at the IRS, but they're fundamentally bean counters. If they count numbers, and if something is accomplished, they check a box. And they rarely look at it from a outcomes, anything from an outcomes perspective. It is viewed as a tax benefit, then they, and required under the law, then they say, yep, that's okay. And if it isn't, then you get audited. And then you have to convince them that it's okay. Next slide. When the ACA was in essence passed, the people that were pushing this recognized that CHINAs were already in the code. And I think many of us saw this as a way to engage the hospital community and to get them more involved as one of many tools in prevention and wellness, not the only one, but one of many tools that we could do to improve the health of the community in a much more holistic way, and also to improve access to care, which is why you see requirements that built on the already requirements for nonprofits to take government insurance, Medicare, Medicaid, to link vaccine authority to reimbursements, to link some of the other advisory boards at the federal level into care. Again, part of a comprehensive look at trying to improve the health of the community. But it also said that recognizing that governmental public health and non-governmental public health had this long history of expertise in broader population health. And quite frankly, hospitals seeing themselves as the care for individual patients um, require that they include them as part of the planning process, which of course happened with mixed results. And I'll talk about that in a moment. Next slide. So obviously, hospitals' perspective, Gerald showed this slide in one slide, but of course, these are the things of what hospitals are counting as community benefit. And the next slide is, of course, the other half of that list. And if you notice, these are very much accounting-like. These are things in which widgets in which you can count. These are things that show up in their financial systems, ways that they can data that they kind of fundamentally collect, and they may be able to count. And as you heard from Gerald, there are questions about how well you count these and whether or not you can actually, once you pull back the onion skin, actually see what happens there, including health professions education. No question that health professions education provides a societal benefit. No question about that. And they build on the educational programs as hospitals have now become major centers of health education. So I don't know that anyone questions about whether or not they provide a societal benefit / community benefit. But the question is how do you count it? What is that value? And is there something unique for nonprofit hospitals different from for-profit hospitals who are also part of academic health centers? I mean, what makes nonprofits who do education different from nonprofits, from for-profits that do health education? Next slide. So there's this inherent conflict for nonprofit hospitals. I mean, frankly, they see themselves as quality care deliverers, and they certainly are. They do amazing things, but frankly, they still see themselves in this individual delivery model. They have struggled to figure out what population health is. Many hospitals, when you talk to them about population health, they guide you to social services that they provide, but for individual patients. When, as you saw from that one survey, there are clearly needs that are much broader for the community. And they rarely pull that data together in a collective way to look at the broad health of the community comprehensively. And they really struggle with this role of their role for population health or / community health. And there are a few measures of success, even though health departments have lots of them. And they frankly could use a lot of those population health measures in terms of measuring what their component of that community health improvement is. And they're certainly in the primary business of delivering health. And because hospitals have now expanded to be not only horizontal, but vertical, they're integrated, they buy physician practices, they have inpatient and outpatient units, they do community health fairs, often primarily as ways to market and bring people into the system. But they're building more and more partnerships with entities in the community. And so in many ways, they are becoming, particularly in places where you have a very weak and ineffective, frankly, local health department, the hospital is the largest employer in town and sometimes is the de facto chief health strategist for that community and could very well be perceived as the broader population health entity in that community if they chose to see themselves through that lens, even though, because that's what they actually do. But they may not get credit for it, they may not count it, and they certainly may not see themselves in that role. Next slide. Of course, Tashina has been less impactful than desired from the original planners. And I remember big debates with many of the hospital associations around the role. I remember getting a call from a senior leader of the American Hospital Association, who was upset because health departments were providing comment to the regulatory part of China when the federal government put out a call for policy and responses to the regulations, and we're wondering why the health departments were so engaged in that process. And I reminded them about 1799 in Paul Revere, that we were in this business before they were in this business. And quite frankly, hospitals have always been involved, but it didn't become an important issue for the C-suite until there was real money on the table and real, at least they perceived risk, financial risk. Then the C-suite became very interested in these community health needs assessment. And quite frankly, there's not a lot of evidence that China's has, which was desired, that would grow the investment in community health needs assessments over time, versus some planting and counting what people were already doing to meet that, again, that checklist, because that's what the IRS requires, a checklist. And there was a lot of infighting, by the way, within the federal government about the role for CDC, because CDC saw themselves as playing a role here, HHS versus IRS. And that was never really got settled as this went forward. And one of the more interesting things, of course, because the C-suite was now more involved, in some communities, this became less of a community activity and more of an isolated hospital activity where, for competitive reasons, hospitals could have gotten together and done a joint community health needs assessment with the health department, share the costs, share the data, agreed on how they collectively could engage communities. But in some places, this still remains an isolated, individual, repetitive community activity done by the hospital, with the argument that we're preserving proprietary and market responsibilities and access. And of course, some hospitals have figured out how to avoid high-risk communities needs by redlining, in effect, functional redlining, by defining the service limitations. So even though they're required to have an ER, which is supposed to have 24-hour, 7-day-a-week access, as you saw from that Dallas hospital for Methodist, which of course, as I understand it, as Gerald said, changed. They had an ER, but you couldn't get to it by defining what populations they will serve by not necessarily recognizing the hospitals right outside their door, or by limiting services. So by closing their OBGYN service or their mental health service or other behavioral health services, or when they find a service is costing a lot of money, getting out of that business. Well, closing a physician practice in that community so it no longer can feed into the hospital setting. So in many ways, even not providing the individual services that provided the access to care that the original planners and promoters of this within the Affordable Care Act were trying to accomplish. Next slide. So going forward, it's important as we think about going forward that 80% of what makes you healthy actually occurs outside the doctor's office. And you saw that from that survey. We know that that's true. But there are people's money you can spend. I love to spend other people's money. And government can partner in ways to address many of those other social determinants, and they can leverage what the hospitals do. Hospitals could send, for example, their lawyers in for hearings around community benefit activities. So having their legal team work to testify on the importance of food programs, on zoning initiatives that can improve health. We know they go in when they want to get zoning to build a heliport or to expand a building or to do something that directly benefits the hospital and its inpatient programs, and maybe sometimes its outpatient programs. But you rarely see those lawyers going in to do things and support the budget of the community health programs that they involve. Imagine they went in and started promoting tobacco prevention programs as a broad community benefit and playing part of broader cancer screening programs. I think the vision, of course, is that we always know this is an essential requirement for hospitals to be part of this thing. And so the fact that it is really an essential requirement on the Chenna gives us the latitude, I think, to demand this more of the hospital community, um, and to actually have them improve the community's health and document what they're doing beyond the individual care of patients. Even if they're simply collecting their collective experience on a disease process for all the patients within their catchment area and reporting on that would be a major, major step forward. Next slide. So with that, I want to thank you, and I'll turn it back over to our moderator, Kate.
Thank you, Dr. Benjamin. Now we're going to hear from Jill.
Can you hear me? Okay. Okay. Well, I wanted to thank Hussein for inviting me and putting together this terrific conference. The first thing I want to say is that I am not a health policy expert. I am. Okay. Thanks. What do I push this one? No. This one. Right? Yeah. Okay. I'm not a health policy expert. I am on the faculty at NYU Law School. I teach 4 courses every year that pertain to tax-exempt organizations and nonprofit law and tax aspects of charitable giving. And I do cover tax exemption for hospitals in those courses. But my job here is really just to tell you what the law is. But certainly I'm not an expert on what the law should be as far as health care policy should be. So, oh, sorry. I'm looking at the wrong place. How do I go back? Oh, no, that's right. Okay, I just want to start with a very sort of basic description of what a tax-exempt organization is, right? Because hospitals fall within that universe. And the tax exemption for organizations described in Section 501C, among others, comes from Section 501A of the Internal Revenue Code, and it says basically an organization described in subsection C or D shall be exempt from taxation under the section unless such exemption is denied under other sections of the Internal Revenue Code. And that takes us to Section 501c3, which I think is the one that probably you're most familiar with. And that sets up a bunch of rules. I mean, it's very interesting because Dr. Benjamin called the IRS bean counters. And I think in this setting, they're not necessarily bean counters. In fact, a lot of people don't understand why charities are regulated in the Internal Revenue Service. Their general job is to be bean counters and to raise revenue. But in this case, they're much more serve as regulators of charities than as revenue raisers, since I don't think this is the place where most revenue is raised. But there are a bunch of provisions here, and we're going to look at it again. It sets up certain requirements, and this is where the standards for exemption come in. I don't think 501R sets up standards for exemption. The penalties there, the sanctions there come from failure to conform to process as opposed to the substantive requirements that are in this section. So I basically think of it as 7 different requirements. The first is choice of form. You have to choose a form. Is there a way to go back here? The red one. Okay. You can see choice of form. It says this is just typical of how poorly the Internal Revenue Code is written. Community trust fund, corporations and any community trust fund or foundation I don't even know anyone who knows what a community trust fund or foundation is in this context. And the real forms you can choose are corporations and then trusts, which aren't even mentioned, and unincorporated associations. The exempt purposes here are enumerated by statute: religious, charitable, scientific, testing for public safety, literary or educational purposes, or to foster national or international amateur sports competition, or for the prevention of cruelty to children or animals. Healthcare is not listed here. It's interesting that promotion of amateur sports is listed, but we all know that people in Congress are rabid football fans, so I call this sports as religion in the Internal Revenue Code. And we find that all over. But healthcare has, I guess it's the beginning of time, been considered to be providing healthcare for the benefit of the community, although the context has evolved, has long been considered to fall within the term charitable. So next we have something called indeterminable charitable class, which really comes from Treasury regulations. And that's just another way of saying you have to be providing a benefit to an indeterminable charitable class, so that it's not really the size of the class, it's the indeterminableness. But that's important in healthcare, as we'll see when we look at some of the language from Revenue Ruling 69545, which says you have to be supporting a big enough charitable class. It happens to say it doesn't have to include the indigent in the class, but in the community. But enormous prohibition, that's the language that says, again, not really well written. Okay, that says no part of net earnings of which inures to the benefit of any private shareholder or individual. That doesn't make any sense. We know there are no private shareholders in nonprofit organizations. I don't know who writes this stuff. But the bottom line here is that this is really the substantive dividing line between nonprofit organizations and for-profit organizations. Otherwise, they're really quite similar. They can make profits, they can sell goods, they can sell services, they can pay salaries, they can pay high salaries. But a nonprofit can't distribute the profit to those in charge of the organization other than as reasonable compensation for services rendered and in some cases for goods provided. So that's really the substantive dividing line between nonprofit hospitals and for-profit hospitals. There also is a lobbying limitation, which doesn't mean much under today's law. They can lobby a lot. There's a political campaign activities prohibition, which the current administration is trying to get rid of. Probably not very relevant here. And then there's a fundamental public policy limitation that says, that comes from case law, that no portion of the organization's activities can be illegal or violate fundamental public policy. So that's what a nonprofit organization, those are the standards for exemption. The sources of the law, where does the law come from for nonprofit organizations? There's statutory requirements, basically Code Section 501C and the Treasury regulations promulgated under the statute. No specific guidance on healthcare organizations. There are specific regulations on education and science and charity, but not on healthcare. The IRS guidance, I think Dr. Anderson mentioned 19 Dr. Benjamin mentioned 1956 ruling, but the current ruling that we're dealing with here is 69545, a very old ruling. There's the Patient Protection Act and Patient Protection and Affordable Care Act, 501R, and there are courts. There are a few cases in the courts that are not relevant really to acute care hospitals, but that do set certain or try to set certain standards. And then there's state laws that threaten property tax exemption. So let's see. The origins of the law come from English law, and the concept of promoting health for a fee as charitable dates back to English law, and the English law is the precursor to the U.S. charities law. You may have heard of the statute of charitable uses of 1601. That's probably where much of our law comes from. But the early statutes in England in the 1500s and 1600s definitely were focused on caring. Hospitals were charitable because they cared for the poor, similar to our laws until really 1969. In 1720, private benefactors founded Westminster Hospital, the first of many hospitals of the voluntary hospital movement, and these were medical hospitals intended to provide health care, right, what we consider health care now, to people in general, not just the poor. And people actually bought memberships. Wealthy people bought memberships. Voluntary hospitals were charities. They're often specifically identified as charities in the statutes, in the preambles to the statutes that granted them charity status. And the English voluntary hospitals movement of the 1700s transformed the meaning of the word hospital from poverty-relieving institutions of old to the medical health care institutions that we think of today as hospitals. So this evolution happened a lot sooner in England. We do have Treasury regulations that define charitable, and remember that healthcare is considered to be charitable. But what's important here is just to see that it's not just relief of the poor. Relief of the poor is one of the charitable purposes, but so is advancement of education, so is advancement of science, so is lessening the burdens of government. So there are lots of ways you can qualify as a charitable organization without relieving the poor. Revenue Ruling 69-545 introduces the community benefit standard and makes it clear that promotion of health is a charitable purpose distinct from relief of the poor. We've talked about it a lot. I'm sure most of you are familiar with it, but there's a 250-bed community hospital, acute care hospital. Independent civic leaders are on the board, so there's community representation. They have an open emergency room, basically open to all in emergent situations. They generally accept all patients who can pay directly or indirectly or through Medicaid, Medicare, or private insurance. And the profits are used to expand the facility and and improve patient care. And the ruling says this is the good hospital. Revenue rulings are like that. They have the very good hospital and the very bad hospital. We don't really know what happens in the middle. And then Hospital B is the bad hospital. That's basically there's just too much private benefit. Five doctors who are basically on its board, and they only grant privileges to themselves, and only the patients of those doctors can be admitted. And it's an inactive emergency room, and so it doesn't qualify. That one doesn't qualify. That's the bad one. Under this ruling, which sets the standards, what charitability requires is an emergency room open to all in emergent situations, and taking anyone who can pay directly or indirectly through Medicare, Medicaid, or private insurance. But we should note that emergency rooms are important under 69-545, and they are important to the poor, but there are other rulings that the IRS has issued that says in certain circumstances, depending on the nature of the hospital and if there are other emergency rooms available, the hospital does not have to have an emergency room even to qualify. What I did want to point out, though, and I think this is important, is what 69, this comes from the ruling. And it says, the promotion of health, like the relief of poverty and the advancement of education and religion, is one of the purposes in the general law that is deemed, in the general law of charity, that is deemed beneficial to the community as a whole, even though the class of beneficiaries eligible to receive a direct benefit from its activities does not include all members of the community, such as indigent members of the community, provided that the class is not so small that its relief is not of benefit to the community. And so it specifically says you can exclude the indigent in the community. That's the law that we have now. That's the language. And so what does it mean? The definition of charitable under current law does not require free care. Charity care, providing charity, really is different than free or even reduced cost care. You can provide other benefits, as Dr. Benjamin was mentioning, to the community. Providing health care for the benefit of the community is charitable as long as the requirements of Revenue Ruling 69-545 are met. Charity care includes health care provided for a fee. The purpose of so if you're just charging a fee, you meet those standards if you meet the other rules in 69-545. The purpose of an exempt hospital is to provide health care. Its purpose is not to relieve poverty. Relief of poverty is a distinct charitable purpose, and this is consistent with charities law. Universities don't have to provide free education. They can charge tuition. Their job is to advance education and science. It's not to relieve poverty. And similar rules apply to religious organizations and scientific organizations and even organizations that foster national and international amateur sports. They don't have to provide free anything in order to qualify. If you're running a soup kitchen, you really have to provide free food, right? Otherwise, you're a restaurant. But other organizations qualify in a different way. I'm not going to talk too much about 501R because I'm out of time. And I just think it's interesting to see what the IRS says that 501R says. This is what's right from its website. And basically, it makes it very much process. It's about process. It doesn't actually, I'm not sure it actually requires anyone to provide free care to anybody. So the IRS is sort of acting as a data collector here and requiring a process, but I don't think it requires free care. So I'm not going to talk about these provisions because I think you're all familiar with 501R. But it doesn't say you have to provide free care to people who are meet eligibility standards. It just says you can't charge them more than you're charging the patients who are covered through various types of insurance or Medicare or Medicaid. There is one case out there that I said I would mention. It's an Intermountain Healthcare case. It involved HMOs. I don't think it applies. It doesn't apply to acute care hospitals. The standards have never been applied. But the IRS argued that this HMO was providing too much private benefit to its members, even though it was a big HMO, and basically said, no, you need to do more. You have to do more. And they went to court, and the IRS won in the 10th Circuit. And the court said, yeah, you have to do the things in 69-545 plus something else. And they didn't say how much else or exactly what else it would be the plus. But there was some thought that it might mean free care. And that certainly would qualify as a plus. Education, research might also qualify as pluses, and there are other sorts of community benefits. It doesn't apply to acute care hospitals, though. The acute care hospital standard is still 69-545. And the only other point I want to make is states traditionally have piggybacked onto the Internal Revenue Service's determinations. So when you apply for tax-exempt status to the Internal Revenue Service and you file a Form 1023 and the IRS grants you a determination of exemption, if you file that with the state, they will usually, for any organization, say, okay, we're going to give you exemption also. You don't have to pay property tax. You don't have to pay sales tax or income tax here. And the property tax exemption, as most of you know, for nonprofit hospitals is really valuable. You have big buildings in a downtown area. It's very, very valuable. The one place they're pushing back, and I forget which of the prior speakers mentioned this, is with hospitals. They're saying, no, we want more. We don't think you're charitable. So, and some of them have tried to implement some sorts of mandatory payments. Some have revoked tax-exempt status, but only for state tax purposes. And the IRS hasn't paid any attention, and they haven't done the same thing. So, thanks, and I look forward to it. I hope this is helpful in understanding what the law is. I'm not suggesting what it should be, but but I've already learned a lot. So, thanks. What? Oh.
And now we're going to hear from Sonya Phillips. Welcome, Sonya.
Good morning. Let's see. Here, is it on? Yep. Okay, great. Good morning. I'm Sonya. And let's see. Like Jill, I'll emphasize that I'm not a health policy expert. So for the past year and a half, I've been working on all things DOGE at GAO. So I am a generalist, and I was a little surprised but glad to be pulled back into working on this report. I'm glad to know that it has some long legs. So this report is about 6 years old now. Let's see. Yeah. And so hopefully some of the information, at least some of the information, is still relevant. And I've included the report number here, GAO 20-679, for anybody who's interested in reading the full report to get a picture of the information that we found. I'll give some highlights, just a quick overview in the time that I have today of some of the information that we found. Tax administration opportunities exist to improve oversight of hospitals' tax-exempt status. So the objectives of this report were to look at what IRS's oversight of how tax-exempt hospitals provide community benefits, and also how IRS assesses its enforcement of requirements related to tax-exempt hospitals included in PPACA. To assess IRS's oversight, we reviewed relevant provisions of the Internal Revenue Code and also Treasury's regulations, revenue rulings, and guidance. We also examined data on community benefit information hospitals report on their Forms 990 and their Schedule H, which hospitals are required to file, and I know this audience is intimately familiar with. We go in depth on that in our report, and I know we'll talk about that a lot more in this conference today. We also reviewed the primary guidance for TEGE's reviewers, the ACA Desk Guide, to determine what topics their triennial reviews of hospitals cover. And we also analyze TEGE's audit referral system to determine the steps IRS has in place to enforce hospitals' compliance with PPACA and the community benefit standard. Further, we compared data on the Forms 990 Schedule H on hospitals' self-reported compliance with PPACA and their reported community benefits with the triennial review guidance. In addition to that, we interviewed select interest groups representing both tax-exempt and for-profit hospitals, and we spoke to national patient advocacy groups that represent broad patient interests. We also conducted a detailed literature review to identify groups that have written on policy implications related to tax-exempt hospitals. And if you're interested in learning more about the interest groups that we spoke with and some of the patient advocacy groups that we spoke with, as well as our literature review, we have in the appendix of our report, we have a detailed objective scope and methodology section that lists out some of those interest groups and those patient advocacy groups. This slide I won't spend too much time on because it duplicates what some of the previous presenters spoke about. The nonprofit hospitals must satisfy 3 sets of requirements and obtain and maintain a nonprofit tax exemption, and it just lists the organizational operational requirements, the community benefits, and the PPACA requirements, and this is a figure that we include in our report. And then the next slide as well, it just includes the IRS Form 990 requirements and the Schedule H requirements. And this is something that we discuss in detail in our report. And I know everyone in the crowd is intimately familiar with this as well. And now to the key findings from our report. We had several findings, but I'll just highlight 3 here today for the sake of time. Congress could clarify the Internal Revenue Code to improve the oversight of tax-exempt hospitals. So with this one, while PPACA established requirements to better ensure hospitals are serving their communities, the law is unclear about what community benefit activities hospitals should engage in to justify their tax exemption. So IRS identified factors that can demonstrate community benefits, but they are not requirements. IRS does not have authority to specify activities hospitals must undertake and makes determinations based on facts and circumstances. The lack of clarity makes IRS's oversight challenging, and Congress could help by adding specificity to the Internal Revenue Code. So if you're familiar at all with GAO reports, then you know that as we lay out our findings, that sets us up to make recommendations and matters to Congress. So the second key finding that I'll emphasize, IRS could improve the transparency of community benefit data. IRS does not collect consistent data on community benefits. The Schedule H includes questions intended to capture information on each of the 6 factors of the community benefit standards, but these questions are located in different parts of the schedule, and hospitals are instructed to address them in different ways. So we have a graphic in our report showing how this reporting structure can affect the comprehensiveness and the consistency in which a tax-exempt hospital presents its community benefits. And so for the last point, IRS does not require hospitals to report community benefit by facility. And the Form 990 Schedule H directs tax-exempt hospitals to report their community benefit expenses at the hospital organization level rather than at the facility level. And therefore, hospital organizations report community benefits in the aggregate for all of their facilities. And so we made about 4 recommendations for executive action and 1 matter for congressional consideration. 3 of those recommendations have since closed, and 1 remains open. So for one of the ones that has closed, IRS should assess the benefits and costs of requiring tax-exempt hospital organizations to report community benefit expenses by individual facility rather than by collective organization, and take action as appropriate. So for this one, in August of 2021, IRS assessed the benefits and costs of requiring community benefit reporting on a facility-by-facility basis. And in their assessment of the advantages and disadvantages, they made the ultimate decision not to proceed. And so in June of 2022, they wrote up their assessment, and they said that the reporting would impose greater burdens on tax-exempt hospitals and with IRS with no tax administration benefit. So that was ultimately their decision. So the second recommendation we made was for IRS to establish a well-documented process to identify hospitals at risk of noncompliance with the community benefit standard that would ensure hospitals' community benefit activities are being consistently reviewed. And in April and July of 2021, IRS updated the guidance for reviews under the ACA Hospital Review Group, and this group performs compliance reviews of tax-exempt hospital organizations to determine if they are compliant with community benefits standards of select revenue rulings and statutes. And those updates add instructions for employees to document case files with relevant facts and circumstances considered during their review that determine whether the hospital organization satisfies the community benefit standards for exemption. And then the last recommendation is that IRS should establish specific audit codes for identifying potential noncompliance with a community benefit standard. And for that one, in May of 2021, IRS did establish an audit code in its case management system under healthcare community benefit standard for exemption. For the recommendation that remains open, we said that IRS should update its Form 990 Schedule H, and instructions were appropriate to ensure that the information demonstrating the community benefits a hospital is providing is clear and can be easily identified by Congress and the public, including the community benefit factors. So as of January of last year, IRS has made minor adjustments to the Form 990 Schedule H. Instructions to indicate that responses should include all of the community benefit factors. However, the changes were not sufficient. For example, 3 of the factors are addressed through open-ended narrative responses that are not part of the quantitative machine-readable files that IRS releases to the public. So a revised Form 990 Schedule H that enables tax-exempt hospitals to present community benefit information clearly and consistently and comprehensively is something that we would be looking for. So this is a rec that we will continue to follow up on. And then lastly, for our matter for congressional consideration, Congress should consider specifying in the Internal Revenue Code what services and activities it considers sufficient for community benefit. And I think this is something that Dr. Anderson also emphasized in his presentation. And this is something that shows promise for, it has a lot of eyes on it, and so it shows promise for possibly being fulfilled. And has ongoing congressional interest. And we were able to testify on this report in 2023 before the House Ways and Means Oversight Subcommittee. And I have that report number leaked here, but it was pulled largely from the report that we did in 2020. And there's been proposed legislation over the past several Congresses that did not move through committee, but this most recent one, which I know a lot of people here are following, HR 9504, is moving, and there is a provision in there for GAO to do some work as well. So we are tracking that in several teams at our agency. And so with that, I'll close out. Thank you.
All right, good morning. I'm Misha Sharp, the Director of Policy for 32BJ Health Fund. If you are not familiar with 32BJ Health Fund, we are a self-insured multi-employer fund. So we serve about 200,000 union members and their families in 11 states and DC. We buy their healthcare benefits and their healthcare using about 5,000 different employers' contributions, and those are employers of all sizes too. So that can be small businesses, small real estate, up to global real estate. But our union members, the 32BJ workers, are building services workers. So they're your security, your janitors, your school cleaners, your airport workers. You probably encountered them as you were coming here today. They serve a lot of different buildings in DC, including the Smithsonian and probably Hopkins as well. So my presentation today is going to be a little different from the ones that you've heard. I'm going to talk about why we focused on hospitals, such a laser focus in terms of purchasing and policymaking. So for us, we have all of our claims data. We've been able to look at it since about 2016, and we've been on a journey, both in terms of purchasing and policymaking, to really look at hospitals as our largest cost center. So you can see here on the pie chart, hospitals make up over half or about half of every dollar that we spend on healthcare, and that's largely been because of that price of healthcare that has gone up over time rather than increasing utilization, acuity. You may see it some in the billing behaviors from hospitals, but it is really by far and away our largest cost center. So on the purchasing side, for the past decade, we've been looking at a lot of different things. From about 2018 to 2022, that was when we really kind of got our claims data. We're able to see hospitals as the largest cost driver and set a strategy to start changing our benefit design. So we started doing that by looking at high-cost services, creating centers of excellence models around surgery and maternity programs. We started tiering our hospital network. So we had a preferred and a non-preferred network of hospitals with $100 copays if you're preferred, $1,000 copays if you're non-preferred, to try and drive more competition and relationships with the hospitals in our market. We actually have seen that be quite productive in terms of where we are now, 2026. We're starting to look at direct contracts that don't include our third-party administrator at all. We also removed the highest priced hospital from our network in 2022. That was because of the prices, but it was also because of the kind of contracting conversations that we were having, where they said, we need to be in every preferred network that you have or product that you offer. It's what we call an anti-competitive contracting clause. And we said, no, we'd prefer to have a more affordable benefit and be able to design our benefit because we are directly paying the cost. So our trustees made the decision to remove the hospital from our network. For the last few years, we've also been building an infrastructure, switching to an independent third-party administrator away from our large Blues plan, using different methods of rebidding our pharmacy benefit manager and our TPA so that we can really be prepared as a self-insured plan to work more independently, to be able to contract directly with hospitals in our market, which has now resulted in 2 large direct contracts, one with Northwell Health, one with Mount Sinai in New York City, where we're targeting prices closer to 200% of what Medicare pays. Our market on average for commercial payments is about 3%. 300% of what Medicare pays. So that's a big cost savings for us. And it's been really neat to see what accountability looks like in that setting where you are having a direct conversation with the hospital. So when you are seeing a really strange billing practice or when we're talking about quality, you're having a direct conversation as the employer purchaser instead of going through your third-party administrator. The impact of this and some of the policy that I'll cover in a moment has been really every dollar you're not spending on healthcare is one that's available for wages and for other benefits. So from 2014 to 2023, wages were rising there at 55%. Healthcare was nearly 40%. Now, in our new residential contract bargaining cycles, wages are going to be at about 70% growth, and healthcare is going to be at about 24% growth. That means our union members are able to get the same wage increases in 6 years that they were able to get in 9 years, which is a really tangible improvement when you're someone who makes about $50,000 in New York City. So in our market, we talked about hospital prices. It's usually not every hospital that's driving your cost. It's the large hospital systems that are having high prices, and like Dr. Anderson talked about, that are usually providing less community benefit, though they're going to be using that as an argument for why they need to charge you high prices. So you can see here on this slide the net asset growth in our market from the 4 largest systems, NYP, Northwell, NYU, Mount Sinai. They've grown their net assets, nearly doubled them in less than a decade to about $28 billion. And when you look at 10 private safety net hospitals in our market, those total net assets are about $100 million collectively. So we've worked in tandem on the purchasing and the policy side. Those have definitely reinforced each other to be able to increase our negotiating leverage when we are talking to hospitals. We have established a labor industry cooperation fund that allows us to do this policy and advocacy because our health fund is governed by ERISA, and under that we're only allowed to engage in activities for the exclusive benefit of our participants. But through that policy and advocacy, we have really kind of taken the mantle for where you hit these critical barriers in purchasing and how we can seek solutions through the policy side. So in 2022, when we were really experiencing some of those anti-competitive contracting dynamics, we introduced a bill to say, let's ban those anti-competitive contracting dynamics at the state level. We've also introduced bills in New York City and New York State that focus on engaging our city and state public employers and their plans, who are commercial plans. They're the 2 largest purchasers in the state, and we want to see kind of the prices and their cost trends to be able to use that as a really valuable benchmark for us and to be able to drive the market forward with more transparency. So we'll talk more about the OHA bill that we passed. But the others that we've focused on most recently are also looking at site-neutral payments in New York State, in the commercial market, and in New Jersey, really enforcing and shoring up their cost growth benchmark program, and those are both still in progress. The New York City Office of Healthcare Accountability has a lot of overlaps with what we've been talking about today in terms of the reporting and the data that they collect. It was established in 2023, 2024, really for the purpose of collecting data on the prices and financials that the city employee health plan pays, but also the New York City local market, looking at its prices across our hospitals, looking at things like community benefit, looking at all sorts of hospital financials. It really still is somewhat nascent in my mind, and so far they've put out a first report. They're about to put out a second report. They're kind of in the base setting and data collection phase before, I think, getting into some of these other items, like convening stakeholders and starting to look more like the offices that you see in a Massachusetts Health Policy Commission. But what they have been collecting data on, the city claims, city employee health spend, New York City hospital prices, using a vendor like Turquoise to put that out there for anyone. They've also put out a public price shopping tool for consumers. They've been collecting hospital data like the 990 Schedule H, the CMS Medicare cost reports, the audited financial statements. We have a New York State system called Sparks that looks at discharges. So they're really kind of serving as a city repository on not only public health, this is run through the health department, but the business of healthcare and making that connection between the two. What has been really interesting to us as a purchaser is especially the city employee health plan data. They are one of the largest purchasers in our market, and you can see very similar patterns. You see spending concentrated at some of the largest hospital systems. You've seen prices going up astronomically on the hospital outpatient side, and you've seen, I think, percentages of Medicare that are increasing similarly a lot on the outpatient side. So that shows us both where the city as a purchaser can be focusing and where we can be focusing in terms of where we apply our purchasing power, but also where we focus in terms of accountability and how to hold our vendors and hospital partnerships more accountable. So that's what I have today, but I'm sure we have some great Q&A.
Yeah, I can hear me. I don't know if Well, I think we're doing well for time. Let me just do another. Yeah, we're doing pretty well for time. So I'm just going to ask the panel one or two questions, and then we'll have time for audience Q&A. And I wanted to start with Misha, actually, but everyone can answer. The research that we've looked at today, we're all relying on, I think of it as like three big data sources. There's the IRS 990 form, where we're collecting community benefit information, and there's the Community Health Needs Assessment, new to us from the Affordable Care Act. And then there is, I think a lot of us rely on the Medicare cost reports for the hospital financial data. You know, what are their margins, what is their payer mix, et cetera. And I think Jill has been helpful in pointing us to, looks like we got to go to Congress to get some things, if we want to get better data, if we want to have tighter definitions. So I guess, Misha, especially because I think your presentation raises this issue, kind of implied by Jerry's comment, that the commercial payers are perhaps actually shouldering what we thought of as community benefits coming perhaps through tax breaks, et cetera. So what would you like to see in terms of these data sources to give you more ways to hold hospitals accountable to their mission?
Yeah, you hear a lot about the cost shifting elements when you start to have these conversations with hospitals about what is a fair price, how do we come to a direct contract. And so I think for us, the information that would be really useful is how much are you truly receiving from all of these different government pots? It's really hard for us to be able to find that. We have really indirect bad math for if we agree that maybe at least on Medicaid and Medicare that we will help you cover that cost shifting, which I feel like is even progressive to say, then how much is that really, that shortfall? When we've calculated it, our prices should still only be about 150% of Medicare, but our prices are 300% of Medicare. So what gives? And what should we as a purchaser be expected to pay for beyond just the healthcare services for our participants, which ERISA very much tells me that's what I'm supposed to pay for, and that's what I'm supposed to care about.
Thank you. And Sonya, I don't know if you would like to speak to this. I know you made recommendations in the report around the 990, and the IRS is sort of, I mean, they said no to the facility-specific reporting, but they're kind of saying yes to clarifying the community benefit definitions a little bit. How would you describe a little bit more about where you think we can strengthen what we're actually getting?
Right. Yeah, and I think that we continue to, I won't say press the IRS, but continue to work with IRS on both of those issues. Like even when we asked them to go back and do an assessment to look at the facility by facility, and their initial assessment came back and they said that they didn't see that there would be advantages, there would be more disadvantages. That's not something that we completely abandoned. Like we still continue to think that there would be benefits there, so that's not an issue that is completely gone away, because we do think that there are some benefits there. But that particular recommendation was closed because they did do what we asked them to do. We asked them to do a cost benefit analysis, and they did do it. And they came back with a result that probably was not the best result that I think most people wanted. However, we do still have the open recommendation about the IRS 990 and the Schedule H. So that's what I would lean into and go back to that being open. And in our report, we have a diagram of all the different places where right now people are reporting information and where that could be clearer. So we do continue to follow up on that. At GAO, we go back to our open recommendations anywhere from 6 months to a year. And as I mentioned before, this report is 6 years old. And so we do follow up on those recommendations, and of course, that matters to Congress. We do, want Congress to be on our side when it comes to helping us to improve these issues and get these recommendations closed. And so, if there's any improvements that they can continue to make to the IRS Form 990 as well as the Schedule H to make these things clearer, we want them to help us to do that and to help the reporting be improved.
Great. And Jill, I know you're pointing us to Congress that given the way this current statute is written, and thank you for correcting me that really it's not there is not even statutory sort of responsibility for serving the poor in the community. Do you think, I guess the question I would give to you is like, given that this is the IRS and all the other limitations that you've mentioned about this agency, it's not a healthcare agency, should we focus on this notion of getting better data and clearer definitions?
Yeah. Oh, is this working?
Yeah.
Okay. Well, I think data and definitions are completely different things. I suppose you need to know what you're collecting data for, so the definitions will help. But I really am not an expert in data or using the data. But I think as far as going to Congress to change the definition of charity, I think that's probably less likely than maybe getting some updated guidance from the Internal Revenue Service. We are dealing with what I call in my classes a geriatric ruling. It means from 1969. And so the way, and I think Dr. Anderson pointed out, the way that healthcare is delivered, and Dr. Benjamin, that the way healthcare is delivered now is very different from the way healthcare was delivered in 1969. So, the Internal Revenue Service could issue a new ruling that would require more specific, quantifiable community benefits. I don't think there are quantifiable community benefits required under any of the laws, the different sources of laws that we have now.
And Dr. Benjamin, I wanted to ask you specifically about the community health needs assessment. Now we have, I guess, over 10 years maybe of experience with the community health needs assessment. Where would you point the IRS? I guess it would be the IRS that would be revising this, the guidance here to strengthen.
Yeah, I would force the federal government to have the HHS, probably through CMS, through CDC, partner with the IRS and make that more explicit, that they partner together to improve the guidelines around the community health needs assessment. That would be one thing I would do. The second thing I would do, of course, is recognize that all businesses have bad debt. They may call it different things, but I don't know if that's necessarily a differentiator between for-profit and nonprofit. And I also think we ought to begin to rethink very carefully about, well, a couple things. One, the fact that you can't improve community health it's impossible to improve community health without addressing the needs of the underserved and lower income individuals. Unless the hospital only sits in a very prosperous community, which certainly does occur, um, generally you cannot do that. So that's something that we need to make sure that we make more explicit. And then finally, this idea that we continue to talk about shortfalls for Medicare and Medicaid funding. All businesses have differential pricing, and hospital pricing is made up. It's complicated, and I don't want to say it's arbitrary because it is not arbitrary, but it is made up. And we charge different people in any business different prices for different things. In fact, we charge people different prices for sometimes the same thing. And healthcare is no different. And so the more we talk about government funding as though it's somehow inferior to private sector funding, I think that's a problem. Now, we don't have that problem in Maryland for hospitals, right, with the all-payer system. That's one of the benefits of the all-payer system, which I would like to see, of course, become nationalized. But I do think we need to think about Medicare and Medicaid funding very differently than the finance people think about it. Because we pay people different amounts of money, but we're paying them for hopefully the same clinical outcome, regardless of what they're charged.
You also mentioned in your remarks that it's sort of duplicative to have, well, we're now down to 2 or 3 hospital systems in most big cities, but should hospitals be mandated to collaborate and should be a sort of community level community health needs assessment? How do you say more about your idea there?
I don't know if you can mandate it and do so effectively because people will always find ways around it, but I think it should be highly encouraged. I think that any argument that if we work and play well together, we will somehow give away our market share, particularly for community health, because community health is a collaborative activity, and you can't accomplish it without bringing everybody in the room. But the time and the cost, the opportunity cost that's wasted by doing it individually, I think is a problem and doesn't make a lot of sense to me. So I think encouraging as strongly as we can, maybe by providing financial incentives, might be a better way to do it. And then hopefully having people like you researchers studying it and showing that gives you better outcomes. Hospitals want a way. They want to do this, right? They want to find a way to improve their market share. They want to find a way to improve their providing better quality care. And no better way to do that than actually being able to give them the data. But the only way you get that is by a collaborative effort between a series of hospitals who, by the way, share patients. They may go to hospital A for one procedure and hospital B for a different procedure. Every time their insurance change, their access to a hospital or a particular service might change. So there's a benefit long-term to doing that.
Well, I think we're ready, Hossein, to open it up to questions from the audience.
Thanks. Question for Jill. Jill, I appreciate you providing some context for hospital tax exemption in the context of 501c3 charitable purposes and activities. A lot of the dialogue around hospital tax exemption doesn't focus on charitable purpose or activities. It focuses in on quantitative standards that hospitals should meet to qualify for exemption or results or outcomes that hospitals should achieve. And I'm wondering, in the 501c3 federal tax exemption context, are you familiar with any type of organization whose tax exemption is contingent on meeting any kind of quantitative standard, like a spending standard, or on achieving certain outcomes or results?
No. I mean, there are various spending tests, for certain types of activities like lobbying, for example.
51H.
Yeah. But no, I'm not aware of that. I don't really think it's the job of the Internal Revenue Service to set those sorts of standards. They are not a health policy organization. And I'm not sure that they should be setting healthcare policy. But it's just not what they do in the exempt organizations area. They're very qualitative standards. They're not quantitative standards. And, I think one of the things that's interesting is that there really are some very important qualitative differences between nonprofit and for-profit hospitals that get lost in the conversation very often. I think statistically, and you all know the data much better than I do, but nonprofit hospitals tend to provide less lucrative services. They're willing to provide things like burn units and psychiatric care and pediatrics and OBGYN. I think if we set quantitative standards, I don't think it would happen at the IRS level. It would have to be congressional. Then they might not have the money to be providing those less lucrative services. And to me, access is one of the biggest benefits of the nonprofit sector, providing access to things that otherwise might not exist. So I think if you did create quantitative standards, they'd be operating more like for-profits maybe, more looking at the bottom line and what they're spending on different things. They'd be looking at the numbers rather than the qualitative differences. So that's a question for healthcare policy experts, and I'm not one, but I think it does get lost in the conversation sometimes.
Thank you.
We do have tools, community health planning agencies that do, at the state level, can address the issues around service delivery, whether you're a for-profit or non-for-profit hospital. Obviously, we've done that in Maryland. And by the way, that's becoming an increasing need in the number of communities that have gotten out of the women's health business, not just for deliveries, but even delivering any kind of women's health service. And we are seeing more and more places that are creating less access to emergency care. So community health planning agencies could play a role, at least at the local level within states, in a more assertive way to do that. That's particularly an issue for rural communities.
Yeah, I just want to say, I do think that the states might have a better shot at regulating some of this. I'm just not sure it's going to happen at the federal level, in the sense that of implementing some sort of quantitative standards or outcome based criteria for exemption.
Other questions?
Hi, I'm Zach Levinson from KFF. Question for Sonya. I was interested in hearing that the IRS didn't think that the facility level information collection was worthwhile from a cost-benefit analysis. I was kind of surprised because it seems like presumably health systems have this information at the facility level and are just adding it up when they report it to the IRS. So I was wondering if you have any more information to share, if the IRS shared more information with you about how they made that assessment. And part of me was wondering if part of the story had to do with what the IRS actually cares about. So maybe that's a question also for Jill, whether they care what's happening at a facility level, or they just are wondering as a system how much community benefit they're providing.
Yeah, I'll see if I can read from what we wrote up actually. When we close this recommendation. It says in August 2021, IRS qualitatively assessed the benefits and costs of requiring community benefit reporting on a facility-by-facility basis. The exempt organization's director signed a memorandum accepting IRS's assessment of the advantages and disadvantages in the ultimate decision not to proceed. IRS provided additional information about this assessment in June of 2022 that described its decision process. According to IRS's assessment, such reporting would impose greater burdens on tax-exempt hospitals and IRS with no tax administration benefit. Specifically, IRS determined that because the exemption is granted at the organization level, reporting community benefits at the facility level will provide no additional tax administration benefit. That's the extent of the information that I have right now. I'm sure there's some more behind that that we could dig into, but that's what I have right now. And like I mentioned earlier to Ann, like that's not necessarily something that GAO would want to let go, because we continue to think that there's more there and that there's more that could be done. And I think that with continued interest and with this new bill that's coming out, there's more work for GAO to come in the future, because they've written work for GAO in the mandate. So as this topic continues to be revitalized, if GAO continues to do more work, this will come back up again, and I'm sure it'll be revisited.
Thanks.
And I think the requirement is in this bill that just got reported out of the Ways and Means Committee, that the reporting be at the facility level.
Yeah, as far as what the IRS cares about, they care about the exempt organization, and if the exemption is at the entity level, not the facility level, what they're going to do here is decide to either revoke or not revoke tax-exempt status, and that doesn't happen at the facility level. I also think, the IRS has been gutted, but even when they weren't gutted, that would just increase the number. If they were to look at each facility and make a determination as to exemption, it's just a huge number of additional taxpayers.
I don't know where Hossein went. Do we have time for more questions before? I think we have one over here. Oh, back.
Some guy back there is trying.
There it goes.
Hi, I'm Nima from Penn State. Thank you, panelists. I have a question for Misha. So given your point of view, I guess, making all this conversation with the payer, with the hospitals, how you go through that contact? Do you have any benchmark? You said you pay about 200% of the Medicare payment to hospitals. So and Dr. Anderson was kind of like mentioning possibly that Medicare and Medicaid are losing on basically those contracts. So what I'm just trying to understand is that, do we have any good guess what would be the cost to hospitals to provide a care, not the charges, the cost, or do you have any basically estimation when you go through that basically conversation or negotiation on contracts? Thank you.
Yeah, it's a great question. I would say the information that we have on how much it actually costs a hospital to provide care is very limited, or I would say, not great. This is why we use Medicare as a benchmark, because Medicare does have their Medicare cost reports. They, year after year, do a more rigorous methodology in terms of determining provider-attested cost and what rate will cover that cost. So in an ideal world, we'd be paying very close to Medicare. However, there are all of these other arguments that we've discussed about shortfalls and all of the other services that hospitals provide that find their way into these conversations when you are talking about rates, in addition to a conversation completely separate from what it actually costs to provide care, which is just what is the market paying, and what do people feel is fair based on what the market is paying. And that is often a core driver for hospitals in these negotiations.
Can I just want to respond. I thought of something regarding your earlier point about it's not outcome based, but under the private foundation rules that were also enacted in 1969 to more rigorously regulate private foundations, since they're not regulated by the public. They're not dependent on the public to buy their goods or give their services or give them money, or buy their services or give them money or anything else. Congress did enact in 1969 a lot of rules that stringently regulate private foundations, and one of the rules is a minimum payout. So they do have to spend a minimum 5% of net asset value annually for their exempt purposes. That includes a lot of different things, salaries, and so I'm not sure it's, we're comparing things that are similar, but there is that 5% minimum payout. And what's really interesting about that is I think it's sort of become a ceiling for a lot of foundations. And so minimum payouts aren't always the best thing. I don't know if you've heard of I'm sure you've heard of donor advised funds, but they're always in the news and they're supposed to be so terrible, but the sponsoring organizations, the sports that are the charities, donor advised funds are not charities, they're assets of these, Fidelity Charitable Gift Fund. Fidelity Charitable Gift Fund is paying out at a rate of 21.7% of net asset value annually from the DAFs. That doesn't mean each DAF is doing that, but the point is that people say, well, we should have the same minimum payout. There's a big difference between 5% and 21%. So it's not always the best thing, but that is a place, I guess, where we have some sort of quantitative determinations and requirements.
I think we had some questions over here. Yeah.
Great. Hi there, Rob Nell with America's Essential Hospitals. And I guess I wanted to follow up on the facility-specific question because, and just get the panel's perspective on how I think a lot of hospitals in recent years have evolved to be part of larger health systems, so providing care not just in the hospital setting, but in the community as well. And I think that's one of the challenges, and we talk about these, services on social determinants of health or whatever, they're not always they're not happening at the hospital, but elsewhere in the community, and it's sometimes hard to associate it with a particular hospital. And I guess maybe a question for the panel too is thinking about like nonprofit parts in other healthcare areas like federally qualified health centers or other nonprofits that do these sort of social determinants of health, what we can learn from the experience there and think about how to best align the requirements as these hospitals have expanded beyond just the hospital mission to reach out into the community.
Dr. Benjamin, do you want to take that one? I don't know if you heard it.
Say that again.
Sure.
Go ahead.
Go ahead. I mean, I guess the part, thinking about we talk about a lot of the community needs assessment work is sort of work outside the hospital setting. But, a lot of the rules that we've been talking about today are sort of hospital-specific requirements and rules, and they don't apply to, like federally qualified health centers or other sort of nonprofits that exist to do that care. And so just wanted to think about, again, the implications of hospitals being part of these larger systems and what we can learn. And maybe, there's stuff from the FQHC space, for example, that might be useful to think about when we think about addressing community needs outside of the four walls of a hospital.
That's why I pointed out that health departments have been leading those efforts for years by bringing all of those people into the room to do that. There are communities where the hospital functionally has played that role. And there's no reason why they can't do that. And the point that hospitals are now becoming more integrated between a variety of both inpatient and outpatient systems, their buying physician practices, et cetera, I think gives hospitals a unique opportunity to do that. And yes, we need to have those rules altered to foster those kinds of collaborations. I mean, at the end of the day, if we're really serious about providing better health care, either individually or collectively, we must do that. So the answer is absolutely. We have the tools to do it. But it does require that at the federal level, that the federal government see it as its role to foster those kinds of interactions and use all the tools that it can to incentivize those. Sometimes with a little bit of a nudge, sometimes with a little bit of a stick, sometimes a little bit of a carrot. And then each state needs to do exactly the same thing. And then the hospitals and other healthcare entities in those communities need to see it as their goal to be helpful. And what government can do is play the data collector, gatherer, disseminator of information. They can serve a convening role as well in partnership with hospitals.
Anybody else want to respond to that?
I actually have a separate question for Jill, but if anyone else has questions.
You know, I would just like to say, Rob, that I've often thought, especially right now, we're anticipating a lot of loss of coverage, and you know, the difference between sort of community spending or community benefit spending by the hospital and perhaps making grant making, and thinking about, you know, in most communities, primary care is kind of a 9 to 5 business, Monday through Friday. And so people go to the ED because even the FQHCs often aren't open all the time. So could there be some collaboration just around simple things like really coordinating hours, and if that sliding scale primary care is available when certain workers, you know, they can't get off work between those hours that often when they're open. So just simple things like that perhaps could, but you would have to do it kind of almost as a grant making function. Anyway, that's a thought. But you had.
Yes, I was wondering about the interaction between kind of nonprofit law and regulations and for-profit, because we do see in our local market, you have every hospital is nearly nonprofit because of New York State law, but some of them have crazy numbers of for-profit ventures all connected. I think you've seen up to 50 for-profit ventures under the same umbrella. So is that odd? Is it limited by
No, and it's not only-
IRS?
I think it's more likely in the healthcare area, but it's not limited to hospitals. I mean, universities do it as well. I mean, they may have, you know, continuing education programs or things like that that are run through for-profits. I mean, there are two types of different ventures. There's sort of the what we call whole hospital joint ventures, where two, you know, a nonprofit and a for-profit get into the venture together. And then there are rules saying basically that the nonprofit has to have enough control to ensure that the purposes of the venture are charitable, because otherwise it's engaging in substantial non-charitable activities and it's going to lose its exemption. But there's a very common type, I think, and I'm not as familiar with the structures as you are, but it's an ancillary joint venture where they'll just drop some function into a for-profit. And then they're really less worried because, yeah, they're going to end up paying unrelated business income tax on that, or maybe it's just a for-profit and they're going to end up paying income tax on it. In the first place, hospitals don't make that much money, right? So income tax isn't a huge issue. But the second place, it's never going to jeopardize the separate organizations, you know, the organization, the nonprofit's tax-exempt status. But I don't think it's uncommon. And the real issue here is when you're dealing with whole hospital joint ventures or whole university joint ventures or things like that, how does the nonprofit guarantee that the purposes of the venture are going to be charitable, primarily? And part of the reason that's such a tough question is that what sort of real for-profit, is going to enter into that joint venture? If the purpose has to be something other than just making money. So, but yeah, I think if the question is it uncommon? I don't think it's uncommon. Maybe more common in New York because every hospital is nonprofit, right?
Any other questions?
We have one question on chat.
Oh, okay.
Yeah, so one of the participants wanted to know, said, as we discuss community benefits, it's striking that I've not heard that the potential lack of community benefits falls proportionally on Black and brown communities. He wanted the participant to speak to that.
Dr. Benjamin, did you hear that one?
Yeah, that's certainly true in urban settings and where the institution sits within an underserved population. That's no question about that. Those community needs, those societal needs are much larger probably in those communities, right? more food insecurity, more lower income, issues with transportation. The fact that the hours the facility is open and access to the community, um, usually the ancillary facilities outside the hospital itself, as we just heard, are not often available when the people need the service, when they're not at work. So that's absolutely true. But it's also true in a state like West Virginia, which is 97% white, where the community benefit disproportionately, where you're not paying attention to it, impacts the lower income white communities. And in rural communities where the service package is often very narrow, and the fact that um, the hospital may be owned by a entity that has a very narrow um, reason for being in the business, and for a range of financial reasons, quote, and they would argue just survival, they unload services that they can't afford, and they may not be able to afford them, not because the services can't be priced properly, but because they can't get practitioners in there. You know, they can't get OBGYNs to come into the community, or they cannot get enough nurses to provide those services. So um, the workforce needs of that community and availability also can impact that. So, but you only get that if you do the needs assessment in an honest way, and then try to find innovative ways to fill the gap by providing those services and partner with people that can bring those services into the community.
Well, oh, we have one. Oh.
Hi, Eva Stalk, Undue Medical Debt. I actually live in Massachusetts, and I know in Boston that they do a joint CHNA, and so it's sort of shared across multiple systems. I was just wondering if you can speak to that as something that you think brings greater benefit to the community.
I definitely agree with that. Yeah.
Okay, well, I think we can bring session one to a wrap here, and I hope we've teed up some good topics for the other sessions to dig into. And we want to thank the panelists, the session participants. I certainly got amazing information this morning that some of it was a refresher, but a lot of it was new. So thank you.